Good afternoon, everybody, and welcome to our session this afternoon, Planning for Palliative Care End of Life. It's part of our 2-week spring online school. I'm Charlotte Stevenson. I'm a business development manager at the university, and we're responsible for supporting any kind of CPD activity from Cardiff University. A few bits of housekeeping before we get going this afternoon. We've got the chat function available if you want to talk to the team, any sound problems, any technical issues, just pop them in there and one of us can sort that for you. We've also got the Q&A, so any questions about the content this afternoon, please pop your questions in there and I'll make sure to ask Dr. Rawlinson at the end, or make sure that we get back to you with an answer. We're all working in different locations, so please bear with us if there's any technical issues, any interruptions, any building noises from next door. And without further ado, I'd like to introduce our fantastic speaker this afternoon. I know a few of you have been on our sessions previously. Dr. Fiona Rawlinson, who is a consultant in palliative medicine and Programme Director at Cardiff University for our Palliative Medicine MSc. Thank you.
Thank you very much, Charlotte. I'm just going to share my screen, I hope, just to get us going. So Charlotte, just checking, is that something that you can see?
Yeah, all good.
Fantastic. Well, it's an absolute delight to be here again. And for those of you who know me well, you know this is a subject about which I feel passionately. For those of you who don't know me well, I hope that this next hour is going to be an hour that resonates with you, that perhaps makes you think a little bit. I'm aware that these are difficult conversations sometimes to have, and in the context of the year that we've all had, some of the issues around talking about difficult things like end of life might be a little bit close to home for some of you. I hope that how I'm presenting this is going to be in a supportive way. I'm very happy to hear from you on email after the event if you've got specific questions. And there are sort of specific signposting on websites, for example, Samaritans, Mind, and cruise websites if you've been really deeply affected by issues around the pandemic. It's been a difficult year for all of us. But the one thing I'd really like to do is, just before we start, get a sense of who's joining us on the call today. So we've got 2 really simple polls to ask you. And Charlotte or Claire, I wonder if you could pop the first question up. And it's really just asking you what your main role in, and please forgive me if you are another. We had to have a little bit of a limit for people that we named, but please tell us what your main role is at the moment. That would be good. And as Charlotte said, as we go through the talk today, there'll be things that I'm really keen to hear your views, just a single word or two on the Q&A as we go through. Right. And so, Charlotte, do you want to close the polling now and let's see who's on the call today? If you've got the results there. Fantastic. So a lovely combination. I know some people will join us a little bit late. So great combination of different roles, which is fantastic. Just what we need for this particular talk. Thank you. And the other question we've got is just where are you joining us from? And again, apologies for those of you who come from other. So there should be another poll about where are you joining us? Where are you joining us from? Because although some of the things I'm going to talk about are very UK based, I think the general principles around the conversations that we need to have apply wherever you're working and whoever you are talking with. So this isn't just necessarily something for healthcare professionals with patients and families. This is actually a topic of conversation that all of us need to be involved with, really. So again, wonderful. So again, a big collection of people. Thank you, Charlotte. Thank you very much indeed. That's great. So welcome. I've talked about having conversations around difficult things in a number of different formats and in a number of different ways. And each time the title changes every once in a while. This title actually came from somebody within my family who isn't somebody who talks about palliative and end-of-life care things very easily. He's a very private person. And as he was getting frailer, we felt that we needed to know, really. We had not had any conversations around what his wishes were. And so this is how he started. And it was a conversation that started at a Sunday lunchtime. And it was just, please listen, I'm only going to do this once. And he had been brave enough to start this conversation, and he wasn't going to do it again because it had taken all his energy to have it. So that's where the title's coming from. So that's what we're going to talk about, really. We're going to talk about the conversations around planning for palliative and end-of-life care. And when my screen wakes up, which it will do, I hope. There we are. So the aims of the session really are going to be thinking on triggers for the conversations. What is it that starts the conversation? We're going to think about useful communication strategies for having and supporting these conversations, and just a little bit on some of the practical aspects of preparing for end-of-life care, just in case that bit of information will help those conversations along. And I think what's difficult is that actually the process of dying is something that we are all going to go through. It doesn't happen to other people. It doesn't happen on the news to other people. This is something that actually will affect all of us. So I'd like you to think about what you do, where you're based. If you're in healthcare, if you're not in healthcare, it doesn't matter. But where might you start or be part of conversations about end-of-life preferences and wishes? And I wonder whether it's probably easier to pop something in the question and answer. So just pop a word or a phrase down. Where is it, if you do, where is it that you hear about end-of-life preferences and wishes, or that you're party to those conversations? Just pop something in the Q&A. So we've got people working in the community, so within the home. Anybody else? Okay, fantastic. So a solicitor from Court of Protection. That's really wonderful, thank you. Hospital home-based, at an initial assessment, in an unexpected crisis, usually in the home. Talking with colleagues on a palliative care ward, ward rounds in the hospital, meetings with providers. Wonderful. So already we can see that these are conversations that happen everywhere. They're not just home. They can happen anywhere. They can happen as part of healthcare. They can happen as part of legal things. Some of us will be having them, as the title of the session prompted, in our families. So these are conversations that can happen absolutely anywhere. Thank you. Such an interesting collection of answers. So do keep popping your answers in, but I'm going to move on a little bit and say, and again, the slides move sluggishly. There we are. But I think underpinning why this is a really important bit of the conversation is to think around that holistic assessment. And actually, I'm going to call it a holistic approach, not an assessment, because wherever we are, whatever we work as, even whether we're in a family, for all of us, we're made up of different parts. And Dame Cicely Saunders' model of total pain, with physical issues, psychological issues, social issues, and spiritual issues, actually, I take that as a model for people. We've all got things around our physical well-being, we've got things around our psychological well-being, our social interactions with people and how important they are for us, and our spiritual world. And our spiritual world is not just religion, our spiritual world is what in the world around me gives me meaning and what gives my walking on this planet meaning. And so I think as we're having these sensitive conversations about the end of life, when we will no longer walk on this planet, I think it's really important to think where they fit with that person as a whole person, holistic assessment, looking after the whole person. And so let's think about what might trigger, who might start the conversations. It might be the person themselves. It might be me if I want to talk about it to my family. It might be our patients. It might be our clients. But the actual person to whom this is important might want to start that conversation just as a personal wish, or because they sense that something's changing and the end of life is actually a concept that's not kind of in the distance somewhere. It's actually something that might be relevant to them. Families will sometimes trigger and start the conversations, and that can be with the person themselves or with professionals, healthcare professionals, anybody involved really in the care of the person. And again, that can sometimes be from a personal experience. So think about families and collections of people when we've now got lots of different sorts of relationships. If you've been looking after somebody in a different sphere of your life who's just died, it might make you begin to think, oh, well, actually in my family, I haven't really talked about that with those around me. Or it could be around a change in the situation. And of course, in healthcare professionals, it may be a change in the situation. And I guess in legal professionals, it may be a change in the situation. Has something changed that makes the end of life seem to come a little bit more into sharp focus? However, there's a big movement to document, to talk about it, to make this part of our conversation. And that's really important. Because if we don't know what people want, if people don't know what I might want, what my preferences might be at the end of life, then I can't expect them to be able to honour them. They have to be on the table. But they're unique. They're sometimes really brave conversations. If you're not somebody who has confidence in speaking about deep things, and many people don't, and they're deeply personal. So they should never become a tick box exercise. And I think it's really difficult, particularly in healthcare, where actually managing large quantities of people, large volumes of people presents challenges. But it's really important that these conversations are thought of as unique. They can sometimes need real bravery to start and continue, and they're deeply personal. What applies for the first person you see may be completely different for the next person that you see. So another area, pop your thoughts now again in the question and answer. So, okay, what happens if the conversations don't happen? What's the consequence if we don't talk about things that are important to us around end of life care? And thank you, Natalie. I your DNA CPR comment there. So yes, what happens if we can't have them? So Jenny starts. Yes, there can be sometimes they can have interventions they might not want. That might be deeply distressing. They might not get a good death. They might just Sometimes it's just what people wish, not too much personal involvement and having it managed for them. Panic and conflict, no choice. Fantastic answers, absolutely. It can affect patient care, be unsatisfactory. Unsatisfactory care is important issues to discuss, plans aren't made. Therefore, you can lead to unsatisfactory end of life. There could be crises that could have been avoided. Confusion, guilt, getting it wrong. And can lead to incorrect, possibly inappropriate management. Difficult sometimes to use words, things like inappropriate, because that implies quite a judgment, but for the person, it might be not what they want. Yes, so it might be inappropriate. It's really important. And I think that bit that I was just seeing there from Cara, things about actually, you know, if we can't able to facilitate some of the wishes, if we don't have the conversations, and then that really does affect the experience of end of life, and it can lead to people feeling, thank you, Wendy, absolutely, very alone and very lost, and that can be families as well. Families don't know whether they're doing the right thing for people. Thank you, absolutely great, thank you. I'm going to move on. But there are lots of things that are difficult to think about if we don't have the conversations. The trouble is, the conversations can be quite difficult, can't they? So in a sense, just reflecting those thoughts, they might not be cared for where they wish to be. They might have things that specific thoughts on treatments, possibly funerals, personal affairs, wills to be made, etc. They might not be able to express themselves. They might be frightened about that. There's a definite impact on grief, and there's no preparation for families. So this is something really big. It's really important. And my last Q&A for the moment is, so we know it's important. We know when we might have these conversations, but it's hard sometimes. I am not pretending it's easy. It isn't always. So what are some of the challenges? Speak from personal experience, whatever. So great. So do you assess, how can we assess the wishes completely? Thank you, Natalie, for starting. Absolutely right. If they're not properly assessed, then that can lead to problems later on. Absolutely right. So, yes, thank you, Eleanor. Is there a mismatch between where the patient is and where the professional is, not just healthcare professional? Time, absolutely right. Sharing informations. Patients not ready to have the conversation. That's really difficult, especially if we can see that things are changing, but that person is not ready. Training the staff. People may not be ready to listen. Difficult challenges about information sharing. You might have a very specific conversation with a person who does not want you to share that with significant others. That's quite difficult. And denial from families. Absolutely wonderful, wonderful collections of answers. Absolutely right. Comprehension of information. Actually, is everybody on the same page? Are people using the same language, or are people using euphemisms and jargon? Comprehension of information capacity, absolutely right. And ability to take part in complex decision making. Thank you, absolutely right. So I'm going to just come off here now, and I don't know why the screen has suddenly decided to go on. What you've written is absolutely right, and these, I'm sure, we're all sharing some shared challenges, because it isn't easy. I've been doing my job for 25 years, and when a conversation goes well, it's a delight, and it's almost a wow, that's why I do my job. But more often not, there's something that is making it challenging. So is there a mismatch? One or other party to that conversation is not ready. Is it the person themselves? Is it their family? Is it the professional in whatever capacity? Is there a mismatch on expectations? So it's not just about readiness, it's about actually what's happening. And Kenneth Kalman in 1984, believe it or not, that was the first time he mentioned this gap. And there's a particular gap at a period of time between the hopes and expectations of the person and actually the experiences and what's actually happening to them. And I think we, all of us, will use, for example, little bits of element of denial from time to time, really useful survival strategy, providing it doesn't get in the way and collide with reality for too long. But sometimes it is useful. The trouble is, if you build up a solid enough wall of denial, it can take quite a long time to take those pieces away, bit by bit, and actually face the reality that the end of life is approaching. A challenge is time in our busy world, not just in the healthcare professional worlds, but just actually to have time to have those conversations in the middle of the myriad of other things that we're all doing. That can be quite hard. And sometimes when the conversations start without warning, you have to do some pretty quick readjusting of whatever else you were going to do that particular next half an hour or an hour to actually focus on what's happening in front of you. And place. Do you need to have that conversation with somebody, but they are not in a private place? Might they find a private place actually a bit threatening to have the conversation? Is it the right place? I've had a number of quite deep conversations with some of my family in cars when we're driving or doing the washing up, when we're sort of concentrating on something else. The meaning of the conversation isn't lost, but I know that if I'm face to face with that other person, that's actually a bit too threatening. And it's just about knowing where the good place is. But sometimes we've not got that luxury. We have to do the best we can in sometimes the most difficult of situations. It's not a perfect world. We know what we'd like to aim for. Sometimes we just have to make it the best we can. But there are challenges just to think through. I think, though, one of the most tricky ones is when there is a mismatch, either in expectation or actually the other person isn't ready for it. So, okay, I said it was the last one. There's not. There's one more Q&A for this bit to go. So, last bit of interaction just for the moment, except for using the question and answer, of course. So, we've said that there are challenges. What can we do to try to facilitate these conversations? So, absolutely. Advanced care planning as a concept, as a thing, as something to incorporate into all our conversations is important. We had the paediatric palliative care short course yesterday, day 2, and one of the issues that we were discussing was a period of stability in somebody's illness and what to use that stability for. And actually, do you use it to have some advanced care planning conversations? And as part of that, do you address the fact that there might be a need to go into hospital to see if something would be put better, something reversible, reversed? And that might happen quite a few times. That's great. There will come a time when it won't be as beneficial, but actually having all of that on the table was something that we were discussing. Wonderful. So some wonderful conversations here. So broach it earlier before admission, very soon after. Documentation, the respect document, absolutely, Anne, as just as a format, as something to focus the conversations. Being open and honest with discussions, making it clear we're open to the conversation and invite. It's something, it might be tricky, but we're used to having that conversation. We can listen. And yes, actually, while you're doing something else, so while you're watching something, while you're doing the washing up, just to sort of to lessen the big impact, but not lose the conversation, if that doesn't sound too daft. Being available, having it as a sort of a routine part of assessment, part of that trusting professional relationship, actually taking time to build things up. So it might not be a one conversation only, it might take more than one. Jana, being ready for it, being ready for the triggers, being ready for the cues. And yes, just making those advanced statements and making it just part of routine life, if you like. Absolutely wonderful. Thank you. All really, really important contributions. Thank you. So, right. So yes, what can we do? We can be ready. I think that's the thing, isn't it? It's being ready. It's having that listening ear out for, oh, that's an interesting phrase. I wonder where that's going. whether it's in our patients or our clients, or indeed whether it's in our own families. Where's that conversation's going? Tell me a bit more about that. That's an interesting thing to say. And actually have thought about our response. Is it something that we personally feel diffident about, conflicted about, a bit ambiguous about? It's a difficult thing to think of our own death. I find it a difficult thing. But actually what I found with being in palliative care for 25 years is that being involved with palliative care really makes me think about living and about, am I really living as full a life as I possibly can? Because I don't know what's around the corner. I don't know what's going to happen tomorrow or next week or the week after. And I'm not being morbid about it. I'm just being really practical. And boy, coronavirus has really brought that into sharp focus, hasn't it? So have we thought about our responses when those conversations start? If we want to have a conversation, who do we want to have it with? And when and where? Do you set it up? Do you say to your nearest and dearest, do you know what? I think there might be things we probably need to talk about. So March the 16th last year, within our family, as we saw coronavirus coming, we had some fairly swift, not always very adept conversations, but we just set out some basic pointers, which we kind of came back to through the year, but it suddenly struck us that we didn't kind of know what people in the family might want. And that sounds a bit of a kind of a dramatic way to do it, but I think it was just thinking, actually, hang on a minute, we've got a bit of catching up to do here. But part of that was also working out how we would communicate within each other as a family. So there's thinking about it for our own personal lives, and there's thinking about it in our professional capacities. But it's be ready and it's listening. And I think it's recognizing that if somebody has taken the bravery, and it might be really brave for them to start that conversation, we need to listen. We don't know what they're going to say unless we listen. And so important, COVID has brought home to all of us. Palliative care issues, end-of-life issues can affect any of us at any time. My heart goes out to anybody on this call who has lost people as a result of either COVID or changed healthcare arrangements. It's been tough, but it has taught us that palliative care issues can affect any of us at any time. So, can we afford not to have the conversations? I want to talk a little bit about the Cardiff 6-point toolkit, but there are other places in Cardiff University where you can find out more about this. So this is a little bit of a teaser, if you like. But when you're having sensitive conversations, some of the tools in the toolkit, which you can use in any order at any time, can be really, really useful. And the toolkit was devised by my wonderful colleague, Nikki Pease, who works in Velindre Hospital. And although it's been around since about 2008, there's a fantastic chapter in the Oxford textbook of communication in oncology, where Nikki really explains in depth the thinking behind the toolkit. In essence, there are 6 tools. There's no particular order to do it. But the first thing to think about when you're having these conversations is comfort. And that's not just the comfort of the person, it's also the comfort for you. If you are feeling stressed, pressured, hungry, need to go to the loo, whatever it is, sitting right on the edge of a very hard chair, it's actually going to be quite difficult to concentrate on what's going on in front of you. So yes, of course, the person who's having the conversation, that's important, but actually your comfort as the other party is also important. And it's not just physical environment, it's also that psychological environment. And I think a particular point around comfort is that psychological environment, not only at the start, so as you perhaps do some ice breaking, as you welcome, as you sit down, as you work out who's who's in the room, if you're on a call, who's listening in. But it's really important to have comfort at the end of the conversation as well. Because during this advanced care planning, future care planning, call it what you will, during the conversation when people are going to be expressing their wishes, what they might or might not want at various points, they're going to be confronting potentially some quite difficult stuff, and they're going to be viewing a version of the world where they are not going to be. And that's a bit weird. That's a bit of a difficult headspace. And so actually you need to make sure as they go out of the consulting room, as they put the phone down, however that conversation ends, they have to be ready to be back in the real world again. So little things, just as you do take care at the start, take care at the end. So we've talked about a lot today. So what are you going to do now? No, I'm going to go out to my car. Okay, have you got your keys? Just make sure that people are psychologically safe to leave the space in which that conversation has happened. Language is words. It's how we use them, but it's also the non-verbal communication. Do things match? Are you breaking bad news but smiling? Are people telling you difficult things, but actually because you're a nervous sort of person, as many of us are when we are out of our comfort zones, we can have behaviours that actually might not help that conversation to happen, and nervous smiling is one of them. However, sometimes looking sad and serious all the time is also a blocker to conversations. So I think we just need to be a little bit aware of what's our body language when we're having the conversations. An example, for example, is if anybody has been unlucky enough to have police arriving at their door with bad news, they have got specific training for how you do that. So you know by how that policeman is going to walk up your front drive or walk up your steps, you know that something is not right. So just think about what signals are people going to be picking up from you. Are you restless? Are you not wanting to hear what somebody has got to say? And that's difficult because if it's somebody you love who wants to tell you what they want, and actually there's a mismatch because you're not ready to hear it, it can be quite difficult to get yourself into that physical space with your body language to say, yes, I'm listening, tell me. But sometimes these conversations happen only once. And so in a way, we have to be agile if we can and be able to read the signs and respond to them. So language is verbal and language is non-verbal. Question styles, really, really interesting. And Ruth Parry from Loughborough and colleagues has done fantastic work on actually the sort of questions that will open up some of these sensitive conversations. And there's a role for all of these question types. So closed questions, yes, no answers. Sometimes you need the closed questions. Is it okay if we have this conversation now? Yes or no? Tell me how you're feeling. That's a lovely open question and will generate lots of information. For some people, if an advanced care planning conversation is a brave conversation, it can be a bit scary because it can sort of open up the field to be so wide that it's really difficult to know how to pluck up the courage to start. For hypothetical questions, or as Ruth Parry would call them, fishing questions, it's great. Some people find that actually when they're feeling a bit breathless, they need to do this. Some people find when they've been into hospital quite a few times that it gets a bit tiring. So just posing a hypothetical scenario to the person can sometimes really open up those conversations. And each of you, depending on who you're with and what the conversation is, I'm sure you will all recognize sometimes when actually you're using slightly different question styles to try to get to the bottom and encourage that conversation to happen. I've personally found, as I've got more adept at understanding the role of hypothetical questions, which is why the Ruth Parry paper has been so interesting, I found that can unlock situations which were a little bit ambivalent and ambiguous, and I wasn't quite sure whether it was okay to keep going and to ask the questions, and I was busy reading the body language of the person in front of me, whether it's my family or whether it's somebody who I'm looking after. But hypothetical questions can really unlock things. So if they're a new concept to you, I would really urge you to explore them because they can sometimes unlock conversations which otherwise might not happen. And sometimes these can only happen once. Listening's the key, though. If we're talking, we can't be listening. This is one of the really difficult problems about doing webinars and doing all the virtual stuff. However, it's much better than not doing it at all. Ideally, in a conversation like this, we should be talking 20% of the time. listening for 80%. It's particularly tricky when you're not face to face with the person in the same room. And we'll come on to that in just a moment, how to make the most out of listening on phones or in the virtual situation. But I think just to emphasize again, listen and silent have the same letters. And not silent, we can't listen. So it's a really important skill. But if you think about it, if we're feeling a little bit anxious about having the conversation, whether we are the director of the conversation or whether we are listening, actually, if you're a little bit nervous, we tend often to cover nerves by talking. And so sometimes it may even have to be a physical thing, like I'm going to sit with my hands in my lap because I'm not supposed to put my hands around my face anymore, and just stop. This sounds important. Let me stop and be quiet and hear what this person has got to say. And there's also in conversations that may be stalling or a little bit spiky, a little bit not flowing fluently, reflection is so useful. So you reflect back a word or a phrase. So somebody says, I've been a bit worried lately. So rather than saying, oh, so what are you worried about? Which would be fine. Actually, if you just reflect that word back, worried, that will then prompt and focus what's going to come next. And it also really tells that person that you've been listening. You've heard that word and you want to know more about that word. So again, a skill that I found, a tool that I found particularly useful to really get skilled in is listening out for those words that are important. And then summarising, which you can do at the end of a conversation, but you can actually do it in the middle as well, particularly if you're getting a bit stuck, if you're not quite sure what the conversation is what the information is coming to you for, if you've got information overload, if you've got so much information and you just need a bit of direction. So, you know, either at the end, so gosh, we've covered a lot of ground. What we've talked about is you're not sure when you get your nest infection that you really want to go into hospital, but you're a little bit frightened about what that might mean if you were to stay home because you think you might need a little bit more extra care at home. Have I got that? Have I got that right? So you can do that at the end, but you can do it in the middle as well. And again, it's showing that you're listening and it's showing that you're trying to get some structure. And particularly if you're working in a very time-pressured environment, it can be really helpful to keep the conversation on track without making it too formal, if you like. So that was a brief romp through the Cardiff 6-point toolkit, and it's a toolkit. Any order, any combination, any situation. It's not a breaking bad news strategy, but you would use those skills if you were breaking bad news. But all of those skills can be really, really useful to help these sensitive conversations. So we've got about 20 minutes to go. Just thinking through what we've said now. We've established that there's a need. But we've established that sometimes it can be difficult to start. And sometimes I think if we're losing our way with this, but sometimes it can feel really overwhelming. Actually, just the usual why, what, when, where, who can help structure things. We know why a conversation is important. We've talked about that in this webinar. We've talked about trust. We've also thought, actually, the fear of the unknown sometimes can be worse than the reality. And if people haven't had a chance to say what they think, sometimes they are imagining situations that may not happen to them. I think one of the difficult things with television, social media, films is that the portrayal of death and the portrayal of end of life is sometimes not at all what happens to people. And so actually really exploring what they're thinking can be really helpful, because some of the things they might be frightened of are very unlikely to happen. But we do need to be prepared for those conversations. We know that they will impact on future grief. But we also know that everybody has individual communication styles. We all do, our families do, our patients, our clients do. And so it's about being able to recognise those styles and be able to match them to get the best conversation. So what are they? Well, we've talked about quite a lot of this already. What's important to the person? And it may be people that are important. Who will speak to me if I can't? If I have a stroke, if I am unconscious, who is going to act as my advocate and make sure that I get the best care? So a legal way of doing that is by a lasting power of attorney. Actually nominating people is really important. Who are the people who I want to know, who I need to know, who need to know things about me? Who are my important people? We mustn't make assumptions. It may not be family members all the time. Who mustn't be forgotten? Who's not here physically for me in Cardiff? Who is important to me but not near enough locally for me? So who are the important people? Place might be important. Place of care or place of death. They may be two different things. And actually that's really important because sometimes people still have very unrealistic expectations about what might be an okay place of death, how things might work. People living on their own without care arrangements, with long-standing illness, may find it difficult for end of life to happen at home. May, not always may. So place is important. Plans are important. Funeral arrangements, wills. Not everybody wants to make funeral arrangements. That's okay. They may not really care too much what happens after they've gone, when they've taken their last breath. They've taken their last breath. But for families' point of view, they may want to know what would be important. And of course, making a will is really important to make sure that some of that succession planning, the legalities, the finances are all in order. When somebody dies, there's a big hole in the world, which does get filled over, but there's a big hole. And if you're trying to sort out some of the legal stuff at that point, which could have been sorted out before, it can be really difficult and additionally distressing. And then progress. So what and how, actually what's progress? The progress of the illness. Is there going to be pain? What's the thing you most dread? What's the thing you most hope for? So actually asking people to talk a little about that will sometimes unpick what people might be really frightened about. But it's a lesson to us, our patients, our clients. The world tells us things about us. So do my family know what's important to me if this is going to happen to me at some point, when this happens to me at some point? What documentation, DNA CPR forms, I know there's been a comment in the chat about that already. This is really important. The DNA CPR form is about CPR. It's about cardiopulmonary resuscitation. It's not about being admitted to hospital. It's not about having antibiotics. That DNA CPR form is a decision just about, if this heart stops, do we want to put electric currents through it and press hard on the chest to try to restart it? That's all that form is about. But it's taken on a life of its own, and in COVID there have been some very difficult things happening. So for some people it's really important to get their views on that. And from the paramedic communities, it's really important to get people's views on that if we can. Some people don't have strong views. They don't want to sign up to anything. They're not sure. But unless we ask people, we're not going to know. And since the Tracy case, no decision about me without me, unless there is a reason not to, we need to be talking with people about this. Our colleague Mark Talbot, Talk DNA CPR website, has some really useful resources. What other documentation are there? The legally binding wills, power of attorneys, and the legally binding advanced decision to refuse treatment. Really important to know if people have got those, and are they still relevant? So sometimes people are very organised and in a particular situation will create them. That might be 5 or 10 years ago now. It's quite useful just to go back and check. We had this conversation a few years ago now. Are things still the same? Not legal, but a guide, future care plan forms, records of best interest decisions, a statement of wishes and preferences. There's lots and lots and lots of the respect forms of forms out there. But documenting it can be really helpful. However, it should never be a tick box exercise. But documenting it can be really helpful in terms of just giving additional support really for the person and the family. When to have the conversations? When the person is asking or is ready, if there's a change of situation, any time. Trying to have it in a calm way. There's no right or wrong here. It's about what's going to be best for the patient, but having it in a calm way out of a crisis and ensure that more options are thought about and talked. and there might need to be time to plan for some things to happen. These are really brave conversations. In our professional role, we might be having them 4, 5, 6 times a morning, probably more, depending on where you're working and how many people you see in an average clinic or in an average sitting. But for each of those people, it's a unique conversation, and it may have taken a lot of courage to get there. So for us as healthcare professionals, for us as professionals, whatever your role, these should never just be the blasé, oh, I'm going to have the advanced care planning conversations. We need to think about them each time, because that's what we would want for ourselves. So can we afford the time? But actually, can we afford not to take the time? And just my whole slide, as always, are you hungry, angry, late or tired? And this is with reference to my colleague Mark Stacey's wonderful baker's dozen bit on resilience in healthcare settings. If you're hungry, angry, late or tired, you're not going to be thinking straight. So you're going to make poor decisions, but you're also potentially going to communicate not optimally. So where to have the conversations, wherever people are comfortable. Sometimes people want to have people around them, sometimes they don't. It's about what's important to the person. But I think relating to some of your comments in the chat, in the question and answer bit before, I think it's really useful just to say, so, you know, we've had this conversation now, who else are you going to talk to? And who else, if people have got questions to me, how would you like me to respond? An example of that, we saw somebody a couple of weeks ago who was very early on in his advanced cancer diagnosis because things had been delayed because of coronavirus. He hadn't wanted to seek help for his symptoms, and he was very clear he had not yet managed to talk to his family. He wanted to do that face-to-face. The UK opened up yesterday, so we were not to have any conversations with anybody else, even if they rang us. He wants to talk to his family, and I hope he's managing to do that over this week now that travelling has opened up a little bit. Interesting things around mental capacity, as some of the legal people on the call will be able to tell us. If somebody has got mental capacity for the task, they may choose to do things in a different way that we might feel is unwise. But if they've got mental capacity, if we've done all the mental capacity assessment, if we've explained things, then they have got capacity to make a decision which others might not agree with. And then our role, whatever role we have, will be in trying to help manage that situation. Where to store the information, somewhere easy to find, behind the mantelpiece in the front room. Not everybody's got a mantelpiece. The Lions message in a bottle, really helpful, because that little canister, which is about 12 centimetres tall, can sit in the fridge. Paramedics, out of hours people know that if there's a sticker in the front door which has got a green cross on a white background, to the fridge they go, and there they'll find a canister. One of the most simplest techniques, and it's really, really worked. So who can start the conversations? Anybody, as I think we've already said. And who needs to know? The people important to that person. Across the country, across the globe, there are different levels of technological expertise in how you store these correctly, if you can correctly, electronically. But the important thing is for people who are likely to be involved in either a crisis or an end-of-life situation, make sure that they know where the documentation or where the wishes are. So this is just a document, a table form of the Cardiff 6-point toolkit, which we then adapted for use in, of course, in coronavirus with PPE, because it's quite difficult to have these sort of sensitive conversations when you're behind a mask. People who are deaf might not be able to hear you. They can't lip read. So there's been a real opportunity lost for people to make a visible surgical mask. But I think there are things about comfort that you can do. Have you warned people? Actually, is it the right thing to be having that conversation in that setting? Sometimes I will go to a house and I will start a conversation and I will quickly see that we're not going to get anywhere. But if I've done the trust and the groundwork right, then I can perhaps have a video call and head off into the more tricky stuff on a video call. But I've done my groundwork right first of all. So there are things you could do for comfort. Non-verbal communication is in sharp focus. So people will see you, the rest of you. Your eyebrows and your eyes are in sharp focus. Really important. The slides will be available afterwards. I'm just mindful of time. Communication skills, this virtual world that we really had to embrace in the last year, virtual on video and telephone conversations. I think comfort, particularly on a phone. Who else is listening? Where is the person? Have you arranged the call? If you're on a video screen, who can't you see? Who's not in the camera angle? Who might be important? So check your own background. Is it appropriate? Is it safe? Are you disclosing patient or client information? Don't forget, again, on video, your face is in really sharp focus, so you need to be focused on the screen. Reading silence is more difficult, and on a phone, particularly difficult, because you've got no visual cues. But you can hear, and you can hear a rustle when people might be actually going to start to say something. And I think just being aware of the fact that it's more difficult, sometimes that's all you can do. With videos, there's mismatch sometimes with time, but try and give people time to actually have those conversations. Thank you very much, Charlotte. So there are some difference with the virtual and the phone conversations, but the essence of the toolkit, how to have the conversations, is the same. And starting that conversation can be the hardest step. I'm going to whiz through these slides because this is just summarising really what we've talked about. This is just, again, a graphic description of graphic pictures. Sometimes people will be better face-to-face. Sometimes people will be better as they're walking side by side. But if there's a wall of denial, or if you've got a protective wall around you because it's not feeling comfortable to have that conversation, there's not going to be a linking of conversation. And I think the other really important tool is just that being in the present. So we're all having these conversations, whether with our families or whether in our places of work, with lots of other things going on. I think multitasking is now, I mean, that's just the norm, isn't it, really? You know, we've got other people that we've seen. If we're in our office, we've got emails, we've got the team, we've got all sorts of things happening. But we have to try and block that out, because for the person having the conversation, it might be the single most conversation that's had. And if things happen quickly, things might be changing and you might need the information that that conversation is held 2 days later, 5 days later, the next week. So if possible, try at that point when you think, oh, right, I think we're going into advanced care planning conversation here. Let me just quickly put everything else around me and I'm just going to focus on that person. If you can, it's really important. Phrases to avoid. Hard. Don't worry. That's difficult, isn't it? We want to say it. But actually, people probably will worry because it's a worrying situation. It'll be all right. How will it be all right? I know how you feel. That's really hard if somebody's going through an experience the same as you perhaps have gone through. But you're not that person. So these are hard phrases because we will want to say them. We will want to say them. We will want to give comfort in distress, but they might not help. So if you can, try to avoid them. We talked a little bit about hope and uncertainty as well, and how difficult that is. And particularly coronavirus, I think, has put that into sharp focus. But I think even in uncertainty, there are some things you can be certain about. I will come and see you. I will call you tomorrow. I will ask my colleagues to call you. I will talk to your doctor to see whether we could get some medicines ready for you. There are some things that you can be certain about, and being certain about them will just add that little bit of structure into an otherwise really uncertain world. Effectively, what we're doing is planning for the worst but hoping for the best, and part of these advanced care planning conversations are listening out, because people will only die the once. Really important we try to get that right for them for that one time. But we're hoping that things are not going to go bad. We're hoping that actually things will be smooth, things will be organised, and the experience will be as okay as it possibly can be. I'm not sure that good's the right word. Okay is probably the right word. It might depend on lots of different situations. And very quickly, finally, if things are not going to be getting any better, there is a lot that we can do and a lot that can be done. phrases to avoid, I think, are just for TLC. We hear it, we see it so many times. Why just? What does TLC mean? Shouldn't we be doing that anyway? You hear people talk about ceilings of care. Care will always continue. It's ceiling of treatment that we are describing. So I think some of the fear around having these conversations is the perception of what end-of-life care is. And I think we've got a big role to play by trying to change people's behaviour and trying to change people's deception. So really just thinking about that end of life, just thinking about what you might need to think about for that loved one is just around comfort, equipment, care and support. And have you got things written down? End of life care, wherever it is, requires support for patients, support for family and support for staff. So we need to be ready. Palliative care, end of life care can happen to anybody, anytime, with or without warning. Coronavirus told us that. But palliative care also tells us how we can live. We only get one chance at this, as far as we know, in this incarnation. So it does tell us how we can live. If we can get it as good as we can, then for those that we leave behind, their grieving will not be as complicated as otherwise it will be. So this is what we hope to do during this session. Thank you for the interaction at the start. As we finish, just think, and maybe not now, maybe you need to have a go away and have a think about it, but are there some things that you might want to do differently? Has it made you think? Has it made you curious? Has it made you question? Has it made you think, oh, help, I need to go and have that conversation? I'm hoping to go and see members of my family this weekend who I haven't seen for a year, and we might just go over some of the conversations that we had back in March time. And here are some useful resources. Oh, great. So Charlotte, I'm going to finish there and just say thank you so much. I haven't given much time for questions, any more questions, but I'm very happy if people want to ask a couple more questions. I'm very happy for questions or comments or reflections.
Oh, thank you very much, Fiona. It's always such a valuable session, I think, from you. And I always pick up lots of important points from it. And I'm not even in the healthcare professional. We've got a couple of questions. I'll quickly ask them and hopefully we can squeeze them in. The Cardiff 6-point toolkit is fantastic. Where can I access or get more information about this?
You know what? That's a really good question. Thank you. And because of our recent community oncology series, I hope in the next few weeks we will generate a simple leaflet which then can be sent everywhere, because it is there in the Oxford textbook of communication oncology, Nikki Pease's article, but the practical aspects of it and the slides, I'm not sure that we've got an up-to-date coronavirus friendly version. So we will be developing something, I think, that we can share, hopefully by the beginning of May. So we will send that in your direction.
Brilliant. We will make sure to disseminate that to anybody who's registered for these sessions, and also to remind everybody the recordings of these sessions will be on YouTube, so you will have time to go back and reflect on everything that Fiona's covered in this session. One more question before we finish. Do you find the age of the patient affects the comms, i.e. are there extra aspects to consider if the patient is younger?
That's really interesting. I think yes, in some ways. I think if we're talking about children particularly, then yes, because the child's developmental age will be a little bit different, and how they perceive death and dying will be different according to their own developmental age. But that's actually really important, to be working with the parents or guardians or those that know the children the best, because they will understand how that child communicates, but also sometimes preparing guardians or parents of children, particularly of a young age. It's sort of the age between about 6 and 10 when everything is really quite clear. Okay, so grandpa's going to be eaten by worms, is he? Or grandpa's going up to space in that rocket that I've just seen. And for a distressed and stressed adult, when you're tired and you haven't had very much sleep, comments like that can be really difficult. But it's not the child's fault. That's just their way of communicating in that age. So I think for children particularly, working with children's services if you can, working with those that know the child the best is important. But in fact, actually for young adults, part of it is just asking that open question and seeing what people's beliefs are. Coronavirus, I think the thing that coronavirus has done for us in a terrible way, but it has brought the immediacy and the possibility of death into everybody's sharp focus. I don't think even if you're in the biggest denial, people die. Prince Philip in the UK has just died. And so actually using this as a trigger to ask people what they think, even if they think it's months off, years off, decades off, you know, what experience have you had? Interestingly, actually with mental health and with some of the suicide issues we've had, more young people have experienced the death of somebody that they've known about than ever before, which is difficult, interesting, but also means that potentially we've got a way in, you know, what's been your experience of death so far? So asking open questions to see where people are, where you can start from sometimes is helpful, and building time. It might take more than one conversation.
One quick one, I think this could be quite quick. Is there a specific toolkit for breaking bad news?
That's a lovely question. There are quite a few frameworks for breaking bad news. My favourite one, I've got two favourite ones actually. One is called Spikes, which is setting perception, information, knowledge, expectations and summarising, I think. Robert Buckman has done some really good work on breaking bad news. The essence of it is finding out how much the person knows already, because you want to try and lessen that gap between what they think is happening and what's really happening. For some people, bad news might not be bad news. It might be what they expect, but you need to find out what the person knows, find out how much they want to know. But then there comes a point when you need to break that news. You can't hide it. You can't dress it up in fancy language that people won't understand. It's got to be clear. And I tend to say you just do it slowly, in chunks. And again, when we're new to this and when we're nervous, sometimes we just talk and talk and talk. But there comes a moment when you say what the bad news is, that there has to be a time for reaction in the person listening. So you have to build in time to see actually what is it, something they expect. Something has changed as a result of the news, and it needs to be given the importance, because that life of that person is going to change as a result. And I mean, this could be any bad news. It could be exam results. It could be being fired from a job. It's not just healthcare. But then there's actually making a plan. So I think it's very difficult to break bad news if there's not going to be a plan for what's going to happen afterwards. So I would look up Spikes, Breaking Bad News and Spikes, or Breaking Bad News and Rob Buckman, and that'll give you those guidelines. But it should never be formulaic. I think we're back to the tick box exercise. People's interaction with you, it has to not feel as if you're reading from a script. It's different every time, and its implications and importance are different every time.
Lovely. Thank you so much, Fiona. I know we've run over slightly, and apologies for that.
Yes.
Just to let everybody know, we will be sending out some information about all the fantastic palliative care CPD courses that we have at Cardiff University, led by Fiona. And don't forget, we've also got the MSc palliative care for healthcare professionals, and also all the modules in that are available as standalone as well. So do take a look at that, and we'll also send some information out about that. And you've also got Fiona's contact details there if you want to pick up on any of the topics covered today, and our Twitter at Cardiff University CPD. Thank you so much, Fiona, for another fantastic session. And there's plenty more available on YouTube from Fiona and the team around this area if you want to go and look at that. And thank you all for attending this afternoon. Enjoy the rest of your day, everyone. Take care.
Thanks all. Bye now.